mycobacterial diseases, TB, and other chronic infections. Today we will be explaining further this lecture, and inshallah it will be really easy to digest and to revise again and again, inshallah. So, this case, you should read it. It came from the textbook, and this patient has a history of productive cough, homeopatasis, and chest pain for 5 weeks, and on and off fever, night sweats, unintentional loss of over 6 kilogram body weight. Even after giving antibiotics, his general practitioner without have never the the general practitioner did not see an improvement, and still the vital signs show elevated temperature and about normal respiratory rate, and almost we can say almost an elevated heart rate. And the examination showed reduced air entry to the apex and at the apex site and right upper lobe of the lung. So we should see that the chest x-ray showed right upper lobe cavitation, and both sputum and blood samples were sent to the lab for further analysis, which we'll be talking further in this lecture. So, what are the so moving to the microbiology of TB. It's a chronic infection by members of the genus of Mycobacterium. So it is a bacteria, and the myco itself came from the mycolic acid in their cell wall, and this gives us another indication of other factors and tests that we will see further in this lecture. So the mycolic acids in their cell wall, they are really thick, waxy, lipid-rich cell walls, and this lipid helps in the survival inside of macrophages. So it is the signature of this organism, and it does not stain by gram. So what we can use is using acid-fast bacilli, so called acid-fast bacilli, because they are rod-shaped and resist the acid decolorization. So we have a different type of stains that we will be using, as well as other microbiological tests and serology that is really vital for TB. These are other further information, and as the doctor have said, that it will be eradicated by 2050, inshallah, but apparently it will take much longer. And it is a serious disease in immunocompromised and age-defining illnesses, and we will see why is that later on in this lecture. So these are the further tests that are used better for TB. As we can see that in gram stain, it's not staining very well, and the Ziehl-Neelsen stain showing acid-fast bacilli, or AFB. Please remember it for further questions in the MSQ, and we can see how the shape of it looks like red in color, and how it's like a bacillus type of morphology. And we have the LJ medium with Mycobacterium have grown after 8 weeks, and please remember the full name of Lunston Jensen or Jensen media, because that is the correct way to answer in an SAQ question. The genus of the Mycobacterium is divided into both a Mycobacterium that is a tuberculosis complex and a non-tuberculosis Mycobacterium, which we will see further at the end of the lecture, the difference between them, which is really important in terms of how we treat the patients and how we want to proceed with giving antibiotics and toxicity to patients. It is really important in a clinical setting more than a basic sciences one. So Mycobacterium tuberculosis and closely related species that cause TB, and we have many species, and some of them we have such as M. bovis, which comes from milk, and involve a BCG strain, and these strains should be vaccinated using live attenuated vaccinations. And as we said, that the all other mycobacterial species except those that cause tuberculosis from environmental organisms that we will be discussing further can cause opportunistic infections, especially in immunocompromised patients, which we will see later on. So, further regarding the microbiology, the key pathogenicity features of TB are intracellular, and the survival inside the macrophages due to prevention of phagolysosomes fusion, and it is followed by a trigger of delayed hypersensitivity, especially type 4, which leads to more formation of granuloma and a cell-mediated immunity. And in severe or even disseminated miliary tuberculosis, TB can cause multi-organ failure, which is really, really dangerous, and we don't want any patient to go through this process. And as we said again and again, that mycolic acid is the main factor for allowing the intracellular survival inside these macrophages. And it does nothing compared to other bacteria. It means that it does not produce the classical toxins, and its pathogenicity depends on the immune response, the cell-mediated immunity. So how does this immune response is detected by tests? We have two tests, the IGRA test and TST, or the tuberculin skin test, and it measures both of them. They are not used for diagnosis per se, but we use them for knowing whether the patient has an infection or not. And they are for the exposure itself, exposure detection, rather than diagnosis. And to be more specific, the TST measures the lump created by the T cells. However, the IGRA, or interferon gamma release assay, measures the products produced by T cells. And both tests cannot differentiate, as we said, latent infection from active one, but they are really useful in detecting recent exposure. And again, if it comes in the test, they are never used for diagnosis. And this is how TB, the pathophysiology of TB goes. We don't want to go through it really, but we can see that the adaptive immunity and T helper 1 cells release interferons gamma to activate macrophages and control infection. However, there is an increase in granuloma formation, and the immune cells form a granuloma, a center with caesus necrosis and a cheesy-like necrosis, outer lymphocytes, and it makes more fibroblasts. And in latent, and the differences between the latent and active TB is that in latent one we have strong immunity. However, in active one we have a weaker immunity with a more tissue damage and spread. So the progression of the disease causes lung cavitation, necrosis, cough, and airborne transmission. And we can really say that TB, perhaps over 70% of people around us are walking with TB, perhaps latent TB. And we have TB within us, but it is not infectious, it is not causing more diseases, or it is not, to be specific, contagious. However, the active TB is much more contagious. You can see that in the TST and PPD tests, it is positive in both active and latent TB. However, it is not contagious, as latent TB is alive, but it is dormant, it is inactive, and it causes no symptoms. Here we can see the different chest x-rays, as we can see here in the epic. Airborne transmission of droplet nuclei is really contagious. A few 8 to 10 bacilli can initiate TB infection. That is why we need to take absolute, really extraordinary measures and airborne isolation of negative pressured room, fit N95 masks, and many others. Whenever we encounter a patient that has a positive and an increase of positive of AFP in the serum, we should take these measures. Exception comes from bovine TB or M. bovis because it comes through ingestion of unpasteurized milk. So we can exclude this TB. However, the other ones that we should take, we should be really careful in terms of treating patients and even controlling the infection. This graph is really important to demonstrate the differences between post-primary and primary progressive pulmonary TB. Why? Because once you get a contact and an infection comes and the cell-mediated immunity starts working on the TB itself, we will see different changes in both primary progressive pulmonary TB and the post-primary TB after the first 2 years. So let me give you a story. We have Khalid, for example, that have been in contact with a TB patient. The likelihood of the infection is really high, as we said. If we only have 10 bacilli within air, it will initiate a TB infection. However, the really interesting thing is that it might not be an active disease. It might be a latent TB, which is what happens to 90% of anyone who is infected by TB. But both IGRA and TST test or PPD positive would be shown positive within these tests. But the patient and Khalid will not be presented with any symptoms unless he has an early disease, which is 10%, a primary progressive of pulmonary TB. And we can see here within the chest X-ray how the TB itself can cause gone focus areas within CT scans and chest X-rays, especially here in the mediastinum area in the middle of the chest wall. And it is really shows how prominent the lymphatic system is involved. And the initial infection can come commonly in children and even a parental one from as a prenatal or congenital TB from the mother, because the mother can pass this infection to the baby and causes gone focus in infant lungs. And the subpleural zone that we can see here and how it is much infected by TB and the complex that is being developed by the enlarged lymph nodes as well as the lung parenchymal lesion shows us a gone complex or gone focus, which leads to immune sensitization, tuberculin granulomas, and many other cell-mediated immunity reaction that can be really challenging to the patient. And within the first 2 to 6 weeks, the healing process will start. The conversion of TST status and IGRA assays will be positive. We can see here how within this diagram how the gone complex can start classifying and causing a subpleural foci. So we have a classified lymph node and an infected lung in the Simon focus and the Simon focus in the apex area, with much more visceral sites through the blood and lymphatics. And the progression is really challenging, I would say, and really tough, with pleural effusion and even cavitations from the healing process that happens. Even the lymph nodes are really involved in this process. However, the post-primary TB or latent one, the reactivation or reinfection, comes really late, even in the adolescence or in adulthood, and the risk is 10%. However, if you are diabetic, have malnutrition, or even you are an HIV or AIDS patient, immunocompromised, these factors can increase the chance of you having a reactivation of TB and being more infected in it. And we can see how the apex of the lung lobes have high oxygen, and the previous sensitization can lead to strong inflammation. And this strong inflammation, as we can see here, causes parenchymal disease, commonly with the lung cavities especially, and even multi-organ failure in really severe cases. And the disease necrosis or cheesy-like appearance, as we can see here in tuberculosis. We took it, I believe, last year. However, this time the lymphatic involvement is really reduced because of the cell-mediated uh, and the type 4 uh, hypersensitivity, which causes more granuloma formation. More granuloma causes more tissue damage. We can see the cavitation here, and one of the most devastating pictures, I would say, is this chest X-ray and CT of miliary TB, which is much more severe and disseminated form of TB, and can come in both the primary and post-primary. It is not only for primary or post-primary. And we can see the millets seed appearance in the X-ray and hematogenous spread of the TB throughout the blood, through the lung, parenchyma, and to various systems. Even the CNS can be affected, and the bone marrow especially, and can occur within 1 or post 1 year, so within 2 years. And it is more prevalent in immunocompromised or low immunity individuals. And the most interesting thing is that the TST test can be negative, and it is because of allergy. Occurs mostly in immunocompromised and people who have some genetic defects or mutations affecting cell-mediated immunity, which will cause a false negative. That's why a clinical picture must be in hand. The most common type and form of active TB is a pulmonary disease, and most cases develop within the first 2 years of the infection, and the post-primary TB is much more prevalent than the primary one. And patients usually are unaware of the first year infection. They have some chronic for months or weeks, they have sputum, but they don't know what is happening within their body. And we can see how an open TB causes the granuloma to break into the bronchiole, and this breakage of granuloma within the blood vessels causes the hemoptysis. We can see other symptoms such as weight loss, anorexia, night sweat, fever. These things are really the major symptoms that are involved within the clinical picture. This slide is really important, both the microbiological test and, most importantly, the microbiological diagnosis of pulmonary TB. We have the C-reactive protein and many other tests, but we want to focus on the diagnosis using microbiological tests, using 3 early morning sputum samples on 3 successive days. So it is used intermittently, but we have to have 3 successive days with the most 2 important tests. They are really rapid, but they are presumptive tools. So they are not really a confirmatory method that is being used, but they are really in handy, and they are different in terms of sensitivity. We have microscopy and special staining, as we said, Ziehl-Neelsen acid fast stain, and nucleic acid amplification test, or PCR, as we say. They are really supportive for diagnosis. However, culture media or culture on specialized media, such as the LJ medium or MGIT liquid media, they are the gold reference method. They are the gold standard, and it may take weeks or up to months, but the susceptibility of testing is really great, and the sensitivity is really great, and we should definitely take them. However, nevertheless, IGRA and TST are really useful but they are not useful here in this situation. They cannot distinguish between active and latent TB, and they are not used in diagnosis. This table is really important, as we said. Acid-fast microscopy is rapid, presumptive, supportive to clinical diagnosis. It has low sensitivity, but it is kind of used in follow-up to remove from isolation especially, and cannot distinguish MTB from environmental Mycobacterium, which we will see at the end of this lecture. We also have the PCR, is really rapid to support clinical diagnosis, and it has preliminary susceptibility, intermediate sensitivity, but it is still not useful for follow-up to make the decision of the isolation or no isolation. But it is really useful in terms of differentiating between Mycobacterium TB and the none, or the one that is environmental Mycobacterium. And the gold standard and the one that we use for confirmation is Mycobacterial culture. It has a much more and higher susceptibility pattern and highest sensitivity. However, it takes so much time, but we use it for more data and confirmation. We might start with the treatment first, and the response to anti-TB treatment can confirm the diagnosis, but this is in the clinical setting. Treatment of TB. First, we have an airborne isolation, combination of antibacterial or antimicrobial therapy, and contact tracing. We should do our best to trace and follow up where the chemo prophylaxis have went and where the patients have gotten a positive or a negative TB. Even just x-rays are being used. Okay, should we wait 6 weeks until we have the culture? No. We always go ahead and have a combination of antimicrobial therapy and a standardized anti-TB regimen, which we took in pharmacology, so I don't want to spend so much time here. But we have rest in peace Isa, rifampicin, isoniazid, pyrazimidine, rifampicin, isoniazid, and pyrazine. Okay, should we wait 6 weeks to start a treatment? Sometimes no. We have a clinical impression and we start with a standardized anti-TB regimen. Rest in peace Isa, rifampicin, isoniazid, and pyrazinamide, as well as ethambutol. These are the 4 drugs that we will be starting right away as a first line to treat our patient. If there is no contradiction, these are the drugs that we will focus on. And the other agents have less active, more toxic, and are much more expensive. We have 2 phases that we focus on. The first one is the intensive phase and the continuation phase. The first one is to prevent any tolerance to be built up and to eradicate as much as possible of TB, and even to be specific, to prevent resistance to develop from TB itself. And the continuation phase of 4 months, up to 4 months, to have a lower dosage on the patient. No more information, important information. Anyone who does not comply goes right away to a committee that will make them comply for the medication. The doctor have told us to just treat this. We have 6 months of isoniazid for contacts of active pulmonary TB. Also public health measures such as pasteurization of milk and BCG vaccination is really important, and it is routinely used in Saudi Arabia. Okay, finally, the non-tuberculosis Mycobacterium. We have slow growers and rapid growers. We should only be concerned with the MyCoBac one, the Mycobacterium orphan complex. The other ones, the names, they were not really important, but if you want, just memorize the slower ones, and the rapid ones will follow. What is the important thing about this slide? You should understand that sometimes we diagnose a patient, but we need to over have a balance of not underdiagnosing the patient and having a disease progression, or diagnosing the patient and having toxicity and antibiotic resistance. Why I'm saying this? Because non-tuberculosis mycobacterium comes from soil, water, environment. It is not transmitted from person to person, making it a disease that is not really contagious. So a patient that comes with similar etiologies and similar risk factors of a TB patient should not be treated with TB regimen. And however, not all NNT positive cultures require treatment, but it does not spread because it does not spread from person to person, as we said, from TB. Therefore, the patient is not infectious or contagious, and the clinical judgment, is needed before starting the therapy. We don't want to give too much antibiotics, start having a patient admitted and putting him in isolation and making his life or her life really miserable because we did not follow the diagnostic criteria. But we should definitely rule out other risk factors such as real TB and malignancies, and positive culture from two sputum samples or even biopsy sample. They are really great to help us exclude any other causes. Okay, I will give you some tips regarding these two slides, the fungal infection one and the parasitic infection. Some of the things that Dr. Lach have talked about. First of all, focus on the immunocompromised ones and know the fungal element, the fungus example, the one in red, and a unique or key clue for each one of them. We can see that the first one, Aspergillus, it's a hyphae candida, hyphal structures, as we can see, so a V-shaped one, branching, and has spores. That's why it's candida. And it causes allergic bronchopulmonary aspergillosis, so it has an allergic thingy to it. Yeast, Cryptococcus neoformis. Also, we have capsulated and capsules, so we should remember in the ink and how it also affects and causes fungal pneumonia in immunocompromised patients. Coccidiosis species, they have spherules with endospores, as we can see, and they are endemic in certain areas. And the pneumocystis, finally, the pneumocystis, from the name cyst formation, stained by silver stain. It causes cysts in bowel fluid, and it comes in it's much more prominent in immunocompromised patients, causing pneumonitis. Moving on to parasitic infections, such as ascaris. So during larval migration, we can see an elevated serum of IgE, and eosinophils and larvae may be found in sputum. This is the key point that we want to focus on, and also the ascaris eggs by microscopy in the stool. So these are the most important, I would say, symptoms that we want to see. However, in cystic echinococcus, which is egg ingested, it is diagnosed by cyst aspiration and microscopy, showing hooklets. And we have the Paragonimus westermani or Giorgio Armani, based on some of my colleagues, undercooked crab or any crayfish. And the important characteristic is we can see eggs in stool and a lavage conformation. as well as eosinophils are found in sputum. Finally, strongyloidiasis and schistosomas in immunocompromised patients. They cause common lesions with or without calcification, like diaphragmophilaris. The pleural effusion caused by the para. And the final thing to remember is the pleural effusion coming from the Paragonimus westermanni. Thank you so much for listening. I know this is a really long and tough lecture, but inshallah, you will do great. I hope that you are having a wonderful day and good luck.